So we are live. We can go ahead.
Hi everyone. After that nice session last time that we had on Degen, Schoolie, and with all the detailed discussion, this time around we have a all clinical session describing various forms of LCS that we routinely encounter and are always confused about. So today we have various scenarios of LCS which will be discussed by Dr. Harshal Bamb in a case-to-case analysis with some interesting papers on tandem stenosis and how to plan, which will be discussed by Dr. Jayesh, and the dynamic stabilization which we have, which will be discussed by Dr. Subhanshu. The first is the most interesting case and the most interesting way where the way we start is the how to improve the post-op care of our patients. That will be discussed by Dr. Akshay Gadiya, where he discusses about the enhanced recovery after lumbar surgery, which he has done an extensive study about. So handing it over to Dr. Akshay.
Thanks, Hriday. Thanks a lot. Let me start by sharing my screen. I hope my screen is visible, right? So let's start the talk with the case scenario.
So Akshay, can I quickly interject? I just want to give an introduction or a background to what you're going to talk about.
No, sir.
Because most of us sitting in India are not even aware of this concept. So actually, there's a lot of technological and technical advances being made in spine surgery. And, we are making headways. But there are some very basic things. And, sitting here, you can say that I don't have access to navigation, computer, whatever. But there's some very basic things which is just about organization and about getting your game right. And it's literally about upping the service that you give, tying things together. So one of the examples is, doing a timeout. When you do a timeout, you take care of a number of potential complications. So you can basically enhance your result or reduce your risk or improve your safety by paying attention to a system. And if you go in a systematic way, there's a chance that, despite not having technology behind you or, the modern gizmos behind you, you can still get a much better result. And if this is out there, and this is something that Dr. Akshay has extensively studied, he's put in a big international paper on this. And I think we have no excuse not to follow this because it does not require time, money. It just requires a will. So with that background, Akshay, I think I'll hand it over to you. Thanks.
Thank you, sir. Thanks a lot for that humble introduction. Let me start with my talk with a presentation. So if we know, just to start the case scenario, this is a 58-year-old male who's an automobile engineer by profession. He had a complaint of low back pain with bilateral leg pain, severe claudication, failed all the conservative line of treatment, tried twice, L5 TFE, still no relief. So, very straightforward solution for this, like conservative treatment, degenerative listhesis.
Actually, it's a blank slide. We can't see anything on the slide.
Is it?
And Jitendra, you need to mute.
Just a minute, sir. I think, yeah.
Yeah, okay.
Am I live, sir, now? Yeah.
Yeah.
Right. So 58-year-old male who is an automobile engineer having a severe lumbar canal stenosis, having a significant low back pain more than his radiating lower limb pains, and as well as having claudication. He failed conservative treatment. We tried twice L5 TFE, still got no relief. And if we look at the MRI, this is like a no-brainer, straight away going for surgery. And the surgery that was planned was, he underwent minimally invasive L4, L5 TLIF. Now, post-op day 1, patient is not able to get out of the bed, quite anxious. And, there are those typical relatives along with the patients there. They will keep on running. Is this a failed operation? Did surgery fail? Ho gaya types. So that leads to surgeon anxiety. And then we think, oh, is there something wrong? Had the implant cut out or did the cage sink in? So we go for a post-op MRI. And post-op MRI looks something like this. Adequate decompression, good release of the nerves, and there's no implant issues. So then again, one keeps on thinking, where the hell I went wrong? And then from there, we think what could have been done to enhance the recovery of this patient. So always, whenever we plan any surgery, we should always think of recovery after the surgery. And my talk will be all about enhanced recovery after surgery in a degenerative lumbar spine. So what is this ERAS? From where did this stuff come from? So this concept was introduced by Kellett in 1995, but was first formalized for colorectal surgery by Ferren in 2005, hardly like 1.5 decade ago. And what does it involve? It involves multimodal and multidisciplinary approach, which has various stakeholders like physiotherapist, pain management team, surgeon, anesthetist, and specialist nurse practitioners. The common motive of all these protocols is to minimize and improve the stress response and optimize the perioperative experience of surgical patients. Now, whole idea of ERAS rotates around maintaining the homeostasis of patient in a perioperative period. The applications of ERAS have been wide in surgical field. It has been widely utilized in colorectal surgery as well as hepatobiliary surgery, so as in cardiothoracic surgery as well as urology, and all the faculties or super specialties of the surgical field have approved ERAS to be really a game changer in perioperative care of patients. So benefits of ERAS mainly it comes from enhanced recovery leading to reduced length of stay, causing quick turnover of bed utilization and reduced pressure of waiting lists. It also aids in reduced complication. It has been shown to have a positive patient response as proved by Liu et al. And also it has been shown to have financial benefits. Now, ERAS in spine surgery. Why one would think spine surgery is a perfect setting for ERAS? And we would say, why not? Now, in the quest of finding the role of ERAS in spine surgery, Tom Wainwright basically he wrote a narrative review and explaining why spinal procedures are perfect setting. He highlighted that these procedures are associated with high amount of pain, leading to slow return of function as well as prolonged hospital stay. And ERAS would likely to expedite the return of function as well as minimize the morbidity associated with the surgery. And Tom Wainwright clearly mentioned in his article that if we follow ERAS protocols, which may in turn lead to reduced length of stay, which will again have a positive impact from financial perspective on the healthcare infrastructure. So we conducted a study where we looked into literature to know the outcomes of ERAS. And we did a ROL for finding the role of ERAS in patients undergoing single level posterior spinal surgeries for degenerative lumbar pathologies. And also we intended to report on the comprehensive list of elements and individual components of ERAS. So this was systematic review, was conducted using PRISMA guidelines. Literature was reviewed between 2000 January to October 2020. We used outcome measures as surgical time, estimated blood loss, length of stay, complication and readmission rates. We compared traditional protocols with ERAS, and for the ease of convenience or for the convenience of description, we divided patients into 3 procedures. First was MIS decompression, second was MIS fusion, either in the form of TLIF or PLIF or posterolateral fusion, and third group was endoscopic TLIF. Inclusion criteria were patients with degenerative lumbar disorder undergoing single level surgery and following ERAS based protocols, while patients with non-degenerative disorders, more than single level surgery, revision surgery, as well as more than ASA grade 2 were excluded. Those with approaches other than posterior and also patients with concomitant CSM or TSM were excluded from this study. So after following PRISMA guidelines, we found 798 papers, which were further screened and duplicates were removed. And after applying inclusion and exclusion criteria, we found 8 papers which were included in analysis for both qualitative as well as quantitative purposes. Now, this is a chart which summarizes the outcome measures from all the studies. Now, this looks quite extensive chart, but if we look at the surgical time, in each of the 3 groups for ERAS, the surgical time was less as compared to the non-ERAS or traditional protocols. So was blood loss. Length of stay was also less for ERAS, and readmission rates, again, only 2 studies highlighted about this when they compared to the traditional protocols, but there were none. For surgical time, only 1 study had which focused on endoscopic TLIF. It concluded that surgical time was more for ERAS. Other than that, all studies, they suggested that surgical time was significantly less. So what are the elements of ERAS? Now, as we know, the patient's perioperative journey involves 3 phases: the preoperative phase, intraoperative, as well as postoperative phase. In preoperative phase, the team, ERA's team, each of the stakeholders have their specific role. And these elements were picked up from all these shortlisted papers. From the surgeon's perspective, a surgeon is responsible for informed consent, as well as patient information material is provided about the planned surgery at the time of consenting. Patients are educated about the surgical procedure, and their risks as well as benefits, as well as pros and cons are explained to them. After obtaining information material, patients read through it, and again, if there are any other queries, they come back to surgeon to ask their queries further. Anesthetists are responsible for health and risk assessment, as well as optimizing the health and medical conditions. However, one particular aspect that stand apart from all of the rest of the protocols is involvement of physiotherapy in the preoperative phase. Physiotherapists, they focus more on informing patients about their journey during the perioperative period, as well as expectations from the surgery and expected recovery, as well as start prehab, or what we call it as a therapy advice given to the patients prior to surgery, because it has been proven widely in the literature that if patients are involving actively in rehabilitation prior to surgery, they have a comparatively better outcome after surgery. While nursing team educate the patient about stopping smoking as well as alcohol, as well as psychological assessment is done using Zunk scale. Dietitians also get involved to screen the patients for any nutritional deficiencies, as well as address them before surgery. Obese patients are encouraged to lose some weight, because we are well versed aware about the problems obesity can cause after lumbar spine surgeries. Well, patients, all day of the patients, they are admitted on the day of surgery. The patients are allowed to consume liquid until 2 hours of surgery, and then liquids are stopped. Solids are stopped 6 hours prior to surgery. Fluid hydration is very important because it helps to maintain the homeostasis. Carbohydrate loading is permitted prior to surgery, because it has been again proven in the papers that carbohydrate loading decreases the perioperative stress response. Preemptive analgesia in the form of pregabalin or gabapentin along with coccyps is administered 1 hour prior to anesthesia induction. Any painkillers or sedative painkillers are avoided, and sedative pre-medications are also avoided. Patients are given oral muscle relaxants for pain relief in the pre-op period. Intraoperatively, again, there are 3 stakeholders. As we know, there's surgical team, anesthetist team, and nursing team. Nursing team starts with looking into the checklist. The WHO checklist is followed widely across the world. Of course, the positioning of patient is equally important, so as to reduce the abdominal pressure, in turn reduce the intraoperative blood loss. Adequate padding of bony prominences is ensured. All the patients receive a mechanical DVT prophylaxis in the form of compressions, stockings, and pneumatic devices. As far as anesthetists are concerned, they administer the antibiotic 1 hour prior to incision, and patients are put on NSAID's infusion 5 minutes before induction. Total intravenous anesthesia is used during surgery, and basically the entire procedure is directed towards, again, maintaining the homeostasis. So fluid therapy needs to be goal oriented, and colloids must be avoided as much as possible. Maintaining a core temperature of patient around 36.5 degrees is mentioned in the literature. That is again to maintain the normothermia, and tranexamic acid is used to reduce the blood loss. From surgical perspective, whenever possible, one must try to use minimally invasive techniques for operating for these patients. Surgical site infiltration with ropivacaine as well as lidocaine or long-acting ropivacaine is recommended. Routine use of drains is avoided, and at the end of the procedure, again, the skin should either be closed with subcuticular absorbable sutures or skin bonding materials. Again, the whole purpose is to reduce the visit of patient to the hospitals, and also prevent surgical site infection by again and again opening the surgical wound. In post-operative period, patients are allowed to consume liquids within 2 hours. Now, this is something which was new to me when I went to Nottingham. I observed this, which is followed quite frequently there. And patients, the catheters are hardly used, but whenever they are used, they are usually removed on post-op day 1. And patients are allowed to have a normal daily eating and drinking from day 1. If possible, patient control analgesia is avoided, but if used, then early discontinuation need to be assured. Systemic opioid analgesia need to be avoided. If at all patient has severe pain, IM tramadol 100 mg is used. There is a wide use of COX-2 inhibitors for adequate pain control, and pain team is responsible for logging the pain scores on daily basis and then deciding or scaling or downscaling the analgesia. Physiotherapists, they assist in mobilization within 2 hours of surgery, and active and planned mobilization is initiated within 24 hours. Patients are provided with the education and information material as well as any contacts that required. If at all any queries, they can always get in touch with us. Uh, when the discharge is planned, patients are considered fit for discharge only when their vital signs are stable, when their pain scores are less than or equal to 4, there were no any intraoperative complications, and when they are able to do the activities of daily living without any problem. After discharge, again, this is very important. A telephone follow-up is conducted either by the ERAS team or surgical team or a specialist nurse on post-op day 2 as well as day 14 to ensure the well-being of patient. Well, one will question why. I mean, including so many stakeholders putting in so much money into developing a single protocol, does that really have any outcomes? So we'll also look into the cost effectiveness. And one of the studies, in fact, 2 studies, they highlighted the role of ERAS in cost effectiveness. This one paper, which was published in Neurosurgical Focus, this was a comparative study of ERAS versus traditional protocol for patients undergoing single level lumbar microdiscectomy. Uh, this study showed that the length of stay was significantly shorter, favoring ERAS group, as well as there was significant reduction in cost of anesthesia as well as cost of surgery. Again, another paper, this was a study from France. Uh, this was about a study of 138 patients going either MI, PLIF or TLIF. And this study showed that the length of stay gradually decreased over a period of 5 years. As the time progressed, the protocols were refined, and the end point of the study was the 5-year follow-up. And at the end of 5 years, they were able to show that length of stay reduced, and the number of patients discharging on discharge after 1 night of stay also significantly increased from 26% to 85%. And overall, there was almost 50% reduction in the nursing cost of the patients. However, there were some limitations of the study. First of all, the data was highly heterogeneous. So I think the quantitative analysis will be less reliable. Throwing in forest plots will be a bit challenge here because the dispersion will be quite wide. So to make a conclusive about the outcome, though it won't fall into statistics, but clinically it appears that definitely these protocols they favor with the good outcome. Variability in the individual elements across all the studies again pose a major problem. There needs to be further randomized controlled trials with the uniform protocols, which could be followed all across the centers so as to have equal outcomes. Now, all of the studies, they had very small follow-up, and we don't know about long-term data, like what happened to patients after 9 months or after a year of surgery. What was the complication rate then? Whether they were any surgical site infections or cut out of metal work or anything else. And lastly, most of the studies, they were retrospective in nature and they lacked the control group. So again, that also becomes a bit of an issue for performing a comparative analysis. So take home message, it's clear that integration of ERAs for single level degenerative lumbar spine pathologies has demonstrated reduction in all the fronts in terms of surgical time, intraoperative blood loss, as well as length of stay. Most important and consistent features are patient education, integration of various specialties, use of minimally invasive surgical techniques, avoid opioids as much as possible, aggressive management of post-op pain leads to better outcome, and of course, early oral intake as well as early mobilization. It favors or it's beneficial for a good outcome as well as improved patient experience. And as we showed, it definitely has a cost effectiveness. And I think this particular aspect of ERAS will be very much beneficial in the scenarios, especially in the peripheral surgical centers where we are really constrained in terms of resources. I think that was all about ERAS in lumbar spine.
It was fantastic, Akshay. It's an eye-opener for all of us. And it's a totally new concept. And just because we have to ask you questions, we're going to still ask you questions. Have you thought about, if you had to implement this tomorrow in my system, have you thought about the 3 or 4 things that immediately a surgeon can, start off, like literally for tomorrow's case?
Yes, sir. I think involvement of prehab, that will be one part which I would say we really lag in our system. So I think
Get a
that can be improved.
physio on board before the surgery.
Absolutely,
Yeah.
absolutely. That's
But
one.
is it quite different? Because most of our patients have had a conservative trial and then they go into surgery. So they've anyway been doing physical therapy. So what you mentioned, is it a bit different from that, like more targeted physical therapy?
I think, sir, the most important thing is physiotherapists which is involved in care need to be uniform, because again, uniformity is something which is very much important. And patients following protocols and seen by a particular team throughout the journey, perioperative journey, again, that's more beneficial compared to the different physiotherapists. So I think that one aspect will definitely matter in such scenarios. As far as other elements are concerned, I think one was prehab. The second one was the use of less and less use of opioid, especially during anesthesia. I think that is one part where we, as a surgeons, don't try to bother a lot or don't try to intervene. But again, if anesthetist is on board and if they understand the importance of this, then I think definitely this will be beneficial. And third will be, I think, the immediate go-to thing will be early mobilization, which we anyhow follow, and early oral intake. So this is something which restores the homeostasis very early, and bring back the patient to the baseline, bring back the homeostasis of patient to baseline, which again aids in early recovery.
Lovely. Any other questions or thoughts by anyone in the house?
The other paper which
Sir,
I'm
Yes.
really sorry. Yeah, go ahead, Rita. I'll complete later.
no, Kushal here, sir. Does only ERAS involve only MIS surgery, or can it be also applied to the open surgery which we do routinely?
Yeah, interestingly, Kushal, that's a good question. Now, preferably MIS, but again, there is plethora of literature to prove that you know MIS as well as open surgeries, they have equal outcome. But again, all those papers, they focus on long-term outcome, outcome after a year or so. While the whole essence of ERAS is to reduce the immediate post-op morbidity. So of course, MIS surgeries, they are preferable. But again, in this study that we conducted, in this systematic review, we also included patients undergoing single level, MIS decompression, where they used, tubular retractors, and they were really beneficial. So all these papers, they had the protocol which favored more for MIS surgery, and the purpose was again the same. So to aid into the early rehab of the patient or early mobilization of the patient.
I think what Kushal was asking was, is this applicable to all surgeries? It's definitely applicable to all spine surgeries.
Yeah.
But ERAS tends to, prefer or tends to feel that MIS gives better results in terms of early mobilization and etc. Isn't it? Akshay?
Yes. Yeah.
Like it
Definitely.
favors MIS compared to open.
Because again, type of surgery is only one of the elements, and ERAS, as you see, it is based on multiple stakeholders.
Yeah, sure. So there's a slight bias towards MIS.
And all
Yeah.
patients have to be discharged on the day one itself, as you mentioned. Means first post-op day, you discharge all patients.
Well, among the study which was done here, if the pain is adequately controlled, again, there was very specific, criteria that were followed for discharge. If pain is adequately controlled, now one can say that is very much subjective. But if the VAS score of patient is less than 4, then they were considered fit to be discharged. Also, if they were able to do their activities of daily living, like climbing stairs and walking independently. So these were the discharge criteria, that were followed in these papers.
And Kushal, just FYI, when I was a PG student, or even a fellow, all spine cases would be kept post-op for 10 or 12 days, in the hospital. And almost most of them would go after a suture removal. And I had a short trip abroad, and I saw in US, even ACDFs would go home, some of them even driving the same night. So it's the same patient, same surgery, and same type of surgeon. So how can they go home early? So it's really opening your mind to being slightly bolder and managing this rather than waiting for it to go down to that 0 on 10 status. So once I came back, even our place, we started sending patients home the next day. So it just needed a change of mindset from a treating surgeon and some element of confidence also. So even daycare discs and all that we've been doing, I think many of us have been doing daycare discs, like a microdiscectomy, admit in the morning and go home at night, that types.
So if I may add something,
Yes, of course.
In another systematic review, I had an opportunity to do one more systematic review as well as meta-analysis for ERAS, and that was for patients undergoing posterior fusion in adolescent idiopathic scoliosis. Uh, in the entire literature, of course, most of the studies were American, and there, the average length of stay was 3.1 days after posterior correction of scoliosis, adolescent idiopathic scoliosis. Now that sounds a bit strange because it's almost 5 days less than the average time taken by a patient in UK to go home after AIS posterior fusion. But again, that's what American people follow, and I think
But
they
there's
do.
a huge, there's some problem there because the insurance doesn't cover them after a certain amount of time for different surgeries. So I have seen people in US going home like this with a lot of pain, but they just have to go. There's no choice because they stay one more day and they'll bust their insurance. Then they go back to a primary care person in near their house, and the whole system kind of rules this. So maybe 70% are legit, but 30% are just pushed out, kicked out of the hospital.
Yeah.
So if I may,
Yes,
if I may
Samir.
say one word on this early. So
Yeah.
I came in late. It was a great paper, but I'm sorry I came in late. But just regarding the early discharge bit. So to echo what Abhay said, in 2003, I went as a consultant to the UK. And so I operated. So it was actually same surgeon also. It's not just it's the same surgeon. So I got a shock because in the UK, those who have worked at our time, now things have changed. The registrars manage everything. So I used to just go and operate. So I was surprised in the evening round as to see these guys, 90-year-olds, fully dressed, sitting and ready to go home same evening. And I got the shock of my life. I said, what? They're going home? Our guys stay for 5 to 7 days. So I found that interesting, but then I realized there are two major differences. One is the mindset of the patient is 50% of the thing. Our patients, we need to cultivate that mindset in a patient that you can go home. So when I started doing microdiscectomies way back, that's 2000, our patients went home the next day. That itself was a shock. In Bombay also, everyone said, Dr. Darwin's patient means next day discharge. Now, of course, they are going home same day sometimes. But the difference between India and UK here, which you have to keep in mind, because you can't follow something without following it completely. See, in the UK, they have a very strong system of care in the community. So this guy, when he goes home, already the council would have put a separate stair lift for him. They would have put a separate railing for his commode. They would have had a social worker visiting earlier to see that there is nothing on which he can fall. He will have a community nurse visiting twice or thrice a day, doing pain management in the house. He will have a community physio who visits them, and he will have access to the GP for pain management, etc. Whereas our patients are entirely dependent only on us. They want everything only from us. So even if the next day they don't, go to the pot, they still want Dr. Samir Dalvi to solve that problem. So that is a slight difference, that their care in the community is well. Whereas suppose we do the same thing and keep sending our patients home. One guy may go to a hut, one may go to a chawl, one may go to a bungalow. So there is no consistency in that, and we don't have a system of caring for them at home, which is an excuse. We can, if you have a big group like what you all have, you all can actually create a system where you send patients home and you have your people visiting them and sorting out the problems in their house so that their hospital stays less. But because our hospital beds also cost less, we are not that much bothered. So it's a bit of you can't completely compare to the West. You have to see what are the differences and what is our scenario and what are our conditions. But yes, on the
Very
whole,
important inputs and very, very relevant inputs, Samir, because I think all of us love this system, but I think we can make some changes in our own thing and at least do what we are able to, isn't it? Any other comment?
Sir, I've got two questions for Akshay.
Yes.
Akshay, have you seen like with age, does the results affect the older people not doing that well, younger people doing well, or it really doesn't matter by following the ERAS protocol?
Well, this was very interesting, sir. Before establishing these protocols at Queen's, there was an internal audit to see does this factor of age really makes a difference, and they really didn't find, sir. There was no statistical difference between the age as well as discharge. Of course, when we confound them with ASA more than 2, grade 2, then things become a bit, the scenario changes. But for the same ASA grades, there was not a lot of difference.
Okay. And the other one was any long-term implication, complication. It wasn't studied in this paper, but you have done the literature review. So do you find any long-term disadvantage of using this protocol?
Not here now, sir. In this papers, which which were shortlisted, none of these papers they had any report on the long-term, adverse events or long-term outcomes. But the one which was the other systematic review, which was done for AIS, there they reported about slightly higher incidence of surgical site infection for patients with ERAS. But again, they didn't find statistical difference, but clinically it was slightly high. The rate was slightly higher. And that too, again, in only one paper. None of the other
And
papers.
those patients who go back home early, how do you manage the wound check? Are they done in the hospital and gone, or do they come back for a wound check?
Sir, all the patients, they get absorbable sutures, and skin is closed with monocryl. So the wound is not a concern there. The wound is not open, and at the end of 3 weeks, when patient is followed by a nurse, the ERAS nurse, she have a look at the wound. If there is any issues, they contact the surgical team.
And there's no drain. He said that drains are being avoided. And here we had a very mini experience where we tried to not put drains and we had problems. And when we put the drains, there were no. But I think it's all anecdotal and subjective. I think the bigger series tell us better.
Yeah.
Sir, can I add something, sir?
Yes, of course, Munjal.
Sir, I had worked for a few months in MIS, and what I have seen in like one level pathology, mostly they don't put drains, and they also in the anesthesia people also means they don't use opioid much. And what they don't actually follow the ERAS, maybe not, maybe like ERAS, but not the name as ERAS. But they give aggressive post-op analgesia and they mobilize same day, and they are given fluids 2 hours or 3 hours when we are on rounds after the surgery. And they are mobilized, and maybe even if they're 80s, if they tolerate well, the next day evening or the day after they are discharged, because they don't put drains, so they are not worried at all. And the blood loss is excessively minimal compared to our surgeries. And I don't know why Akshay has mentioned that there is reduction in surgical name. That is maybe surgeon dependent. That's what I feel.
Nice, good inputs. Good paper, Akshay, and keep working on this and try and make a protocol for us here, and we'll all just follow that.
I think, sir, the entire crux is yet to happen. Once we throw the forest plots, we'll get to know really, does this statistically make any difference? So probably after that.
It's exciting, and it's it's tempting to do it.
Sure.
Thank you, Akshay, and thank you for making time for the talk. We'll quickly move on to Subhanshu. Subhanshu, you're next, isn't it? And I think we're going to now discuss. Harshal, you want to take over?
Yeah, I'll start, sir. Basically, we'll start with the cases,
Okay.
and as and when the case comes,
Okay, got it.
we'll talk about it. Yes.
So the plan here is to discuss some contentious degen lumbar cases, not the standard lumbar stenosis, but something that's slightly hatke. So it could be degenerative, it could be lysis, it could be skip lesions, it could be multi-level lesions in young people. So it's more of a practical, what the foot soldiers see on the road rather than the theoretical discussion of LCS. Yes, Akshay, all yours.
Is it visible? Yeah.
Yes.
So, good evening. We are talking about today lumbar canal stenosis, current clinical scenario, current concepts and some clinical scenarios. Why basically we talk about lumbar canal stenosis is because it has varied presentation. There's no defined diagnostic criteria for diagnosing lumbar canal stenosis. There's more often than not clinico-radiological mismatch. The surgical options are varied, right from open surgeries to minimally invasive surgeries to endoscopic surgeries. And there are different surgical principles, whether to fuse, to not to fuse, to corridors option opted for fusion. And when we do a read a bibliographical study, which is mentioned here, we see there are a lot of current literature. Even in the last 1 month, in all the spine journals, we have found a lot of journals, presentations regarding lumbar canal stenosis. For practical purposes, we divide lumbar canal stenosis in simple lumbar canal stenosis and a complex lumbar canal stenosis. A complex lumbar canal stenosis is always associated with some other adjuvant lumbar pathology, which can either be degenerative listhesis or degen scoliosis, some tandem stenosis, a developmental LCS, and many more, multi-segmental instability, adjacent segment disease, or ONE. Coming to the cases, Munjal will take up the first case. So this was a 70-year-old female. She came with a significant neurogenic claudication of less than 5 minutes. Her leg symptoms were significantly more than back pain. Her neurology was intact, and her range of motion, only extension was painful. Munjal, any comments about the radiology?
Means I can see there is lesion list in last but second mobile segment. And the last but third mobile segment, there is small snode as well as early, you can say, gray
Some
type.
electrophysiology, yeah.
Yes, is there. Yes.
Yeah. So how do you want to proceed further?
Here the dynamic X-rays are seen, and her leg pain is more than neck pain.
Yeah.
So I will. So we have to see how her
conservative management, and she has tried blocks and she has failed. So we are yeah.
So most likely in this type of case, I will try to address only L4-5 if at all I plan to fix, and maybe undercut L3-4.
Okay. And why fixation in this case? Any particular reason?
You can see the dynamicity is there on the X-rays, so better to fix in this case.
Okay. Fine.
So there's axial as well as translational mobility on flexion. The disc space totally is collapsing, and there's front and back movement also. And the question, Munjal, would be interbody or then just posterolateral?
So the way I have been trained, I would like to do posterolateral.
Not do an interbody here.
No, sir.
Anyone wants to challenge that? It's a significant axial instability. Also, does anyone care for the sagittal profile, etc. over here? Radio silence means no one's thinking about it. So that's good news, because for a one level, you should not really worry about this, because you'll go crazy if you start doing a sagittal profile. It's an imbalanced spine, and it's likely that it'll suggest that you have to go all the way up. So for a one level, you don't have to really worry about a sagittal profile in a 70-year-old.
Yes.
And, so one level interbody versus one level PLF, any takers? Harshal, what's on your mind?
So, sir, I know about the case. I was there for the surgery, and we decided about looking at 70-year-old female. We decided about doing a one-level posterolateral fusion, and that was the post-op X-ray. So, whenever a degenerative listhesis comes with a lumbar canal stenosis, we have always a issue in mind in decision making that whether to fix or not to fix. So there we look for radiological signs of instability. And apart from that, I would like to know from the esteemed faculty and panel, how much the tall disc, the back pain and young patient come into decision making, sir?
Actually, if I may say, in this patient, what worries me, so I'm just I'm the guy who always finds faults, as you would have realized by now. So what worries me is all her spine is fused above L3.
Yes,
and
sir.
L4-5 we have fused. I'm just worried about that L3-4 segment. I don't have an answer. I'm not saying you should prophylactically fuse L3-4, but I'm just worried about it. Especially you see the post-op AP.
Yeah.
I'm like worried about that L3-4. It's going to go. I mean, that L3-4 is going to go. The other thing is that, especially given that in this case, I would be worried about so-called sagittal profile, and I would not be happy doing a posterolateral fusion. I would do an interbody, and the reasons for that are, surprisingly different. You may be surprised at my reasons. See, a good posterolateral fusion which works is, according to me, more difficult and is more tissue damaging than an interbody fusion. Because in an interbody fusion, you just remove one side facet, you're in the disc, you scrape out the disc space, put in a cage and put in bone graft. But to do an intertransverse fusion, you have to go to the tips of the transverse process above and below, which is a significant denervation, significant devascularization, and your midline incision has to be much, much more to be able to reach laterally. Or otherwise you do a Mickey Mouse. See, people do a Mickey Mouse fusion, which means they just choke out a little bone graft and do it. But to do a proper intertransverse fusion, you have to go to the tips of the transverse process, You have to decorticate with a burr or with a nibbler till it really bleeds. You have to put the holes and tap the holes of the screws first. Then you put bone graft on that. Then you put the screws and the rod. That's the only way to do a good stroke perfect intertransverse fusion. So even for that reason, that the time taken, the blood loss, etc., is much more, and for the fact that this patient who has a taller disc should have a cage in front, I would do an interbody fusion for this case. And people who are expert like Arvind Kulkarni and Vishal Peshattiwar would do a MIS TLIF for this. So I am not so good yet. I think I am not as good yet to deal with a central stenosis like this. But MIS TLIF also people who are experienced can do. You know, you need to be separately experienced in decompressing these through a tube with the over the top, as well as separately experienced in doing a MIS TLIF. So when you have both of those together, then you can even do this MIS. But I would do a TLIF for this, and I would do a TLIF for this. Yes. And I worry about an L3-4 after
the post-op X-ray, na, Harshal?
This is the
discussion happening just to see the, because there's that little retro at the top, and there are these anterior osteophytes, like Samir said, are tending to fuse the spine.
And that L3-4 is the mobile segment left now.
In this X-ray, I'm seeing failure. I'm seeing this patient coming back. Sorry to say, something not quite right in this. Yeah.
Fine.
But anyway.
So regarding fixation, we look for radiological signs of instability, which are mentioned here, but we also look at the facet. Facet, we know that it has some role in pathogenesis also, and there's also surgical relevance in decision making. When we look at the facet, we have cyst and effusion. Basically, facetal. There's a very good literature from AIMS published this year only, that facetal fluid had a positive correlation with presence of dynamic lumbar degenerative listhesis. And they also said that whenever facetal fluid is more than 1 mm, you should always do a flexion extension radiographs. And there are various classification systems which are put forth for facetal cyst. This was one of the recent ones from Australia, where they look for canal compromise and degree of listhesis. And in this, they have also given the what treatment should be done for which grade of facetal cyst. And coming to orientation and arthropathy, we know that there's a significant association between facetal tropism and orientation with development of degenerative lumbar diseases. And amount of facetectomy which we do has also been shown to have a correlation with the surgical outcome, clinical as well as radiological, and some it is also associated with failed back syndrome. Coming to case 2, Akshay sir, you'll take this.
Can I ask a question? How frequently, sir, do you consider retrolisthesis as a instability and address it? Is it considered as?
Harshal, retrolisthesis. What's your take on retrolisthesis?
Sir, so retrolisthesis, we always look for the amount of retrolisthesis. If it is mobile on a dynamic view, dynamic X-ray, we tend to fuse it. But in elderly population where we are not gonna, we want to limit the levels of fusion. And if there is a associated lumbar canal stenosis, we just do decompression. And again, we look at the facet and everything. If there are signs of radiological signs of instability, then we'll fuse it.
So I think Kushal's question is because literature says retrolisthesis is more unstable than prolisthesis, because prolisthesis has facet joints which still are restraints, but retrolisthesis has no restraint. So it's supposed to be a more unstable condition. And even I've read that over and over. But in practice, I think most of us tend to overlook a grade 1 retrolisthesis and don't consider it as unstable unless it's a mobile retrolisthesis. We don't take cognizance. Or if you're planning a fusion and above there's a mobile retrolisthesis, of course, you're setting it up for a problem. So I think aside of that, just a standalone, grade 2 prolisthesis is definitely considered something for fusion, but say a grade 1 retro is not considered a surgical problem.
So can I add something? I think yes. Moreover, sir, around 2 millimeters of movement is permissible by the facets itself. So that grade 1, again, whenever you see most of the cases of retrolisthesis, there's hardly a more than 2 millimeter movement. And again, the patients who have near grade 2 listhesis, they are more symptomatic as compared to the grade 1s. So I think that sounds true. Like we tend to underestimate, but again, at the same time, the movement at facet is also equally responsible for that listhesis.
Right.
So I think retrolisthesis is actually a stable situation. I don't know the literature, but I can tell you about my practice in so many years. I'm never bothered about retrolisthesis. It doesn't even strike me in the eye. There is only one place where retrolisthesis bothers me and I do something. I'll explain the scenario. Some patients have L5S1 degenerative stenosis, not L4-5. This L4-5 is extremely common. Some have L5S1, and with that they have a retrolisthesis and very big facets. Now these are the patients who, according to me, have exit foraminal stenosis, what is also known as up-down stenosis, which is worsened by the retrolisthesis. And these are the patients where I worry about the retrolisthesis, and I am less worried about fusing L5S1 because you're not creating a floating segment. So therefore, these are a very small subgroup of patients who I would fuse for a stenosis with a retrolisthesis. So you don't get many out of, like, you know, every 10 to 15 stenosis ke baad, you will get one of these where they have a L5S1 stenosis with a retrolisthesis. And that is a guy who I fuse.
Interesting, very interesting, but logical.
True, sir. So Akshay sir will take this up. This is a 64-year-old male. Claudication time was less than 5 minutes. The claudication was acute on chronic because he had fallen 2 times in last 1 month, and the symptoms have worsened. He's underwent TURP in last 5 years twice. The dorsiflexors, ankle dorsiflexors and EHL bilaterally is 3/5. The knee reflex was brisk, and there was a hypostasia significant on L5 and S1 bilaterally. So these are his images.
He's had a laminectomy, I think. You can see.
He's had spine surgery also, man. He's got a spine surgery.
Yes, sir. Yeah. Laminectomy done.
Yeah.
Looks like he has a last movable segment laminectomy was done. And
Done.
what we can see from MRI is above the level of laminectomy, which appears to be the third last mobile segment, there is quite severe stenosis to an extent where the roots are clumped in the fecal sac.
And there's a cyst at 4-5 on the left.
Yeah, there is a cyst on the left side, and I think there is a history that he had a fall.
Yeah, 2 falls in last 1 month. Yeah.
So
I think I will be interested to have a look into the screening of whole spine here.
Absolutely.
Know exactly what was the reason for his falls. Was it this LCS or was it? Yeah, there looks to be.
Absolutely, you nailed it.
There is a stenosis.
Yeah.
So I think it's an important take-home message that typically lumbar claudication comes with pain, not with deficit or instability or of gait. So if there is instability of gait, it's a sucker trap, and don't miss if there's a myelopathy or any neurological central nervous system condition that's feeding into the problem, and dissociate the two. And so here, go ahead, Harshal.
Yes.
Yeah. So here it seems that patient has, I think, proximal stenosis as well.
Yeah. So how would you plan, sir? How would you plan this case further?
Yeah, for this patient, I think I'll be interested to have a look into the axial scans of the cervical spine, and assuming there would be
there's a stenosis there.
Severe stenosis. Yeah. I would look into the surgical fitness of this patient, how fit this patient is. Now, if this patient is really quite fit to undergo surgery, then what I would offer is tandem decompression at both the levels. But if there is issues regarding fitness, then I would try to curtail my decompression only to the cervical spine, and then decide based on the outcome how to proceed with the lumbar spine.
Priyank, sir, your take on this? Would you do cervical first or lumbar first?
I would do a tandem decompression for this patient.
Yeah, as you see, there's already a difference of opinion in the team. So again, this was basically regarding the fitness of the patient, but there's always an issue when there's a tandem stenosis, whether to operate lumbar alone, to operate cervical alone, to operate one first or the other first, or to do it stage procedure. So we'll have a literature review by Dr. Jayesh Bhanushali. He's a consultant in Thane. Jayesh, over to you.
Yes, just a minute. I'll be sharing my.
Up to 30% of lumbar stenosis have an associated cervical stenosis, and it's either clinically unnoticed, means it's just incidental, or it is clinically present. And I think most of us tend to base our decision, so if you have a tandem stenosis with one that's obviously clinically there and one that's hidden versus both are obviously clinically there, I think that's where the decision making lies. Thank you, Jayesh. Please take over.
Yes, sir. So is my screen visible?
Yeah.
So I'm going to do a literature review whether in case of a tandem spinal stenosis, we do a stage of simultaneous and to see what is the consensus over the years. So tandem stenosis, as we all know, it's a triad of intermittent claudication, neurological claudication, mixed upper and lower motor neuron signs, and a complex gait disturbance. This was described by Dr. Paul Teng in 1964. So there was this study, very old study done for tandem spinal stenosis, where patients had undergone lumbar and cervical stenosis, but it was initially there was no literature or a guideline to do a tandem decompression. So patient had undergone so there were total 11 patients which were included in this studies. 4 underwent simultaneous and 10 patients underwent staged lumbar after cervical or cervical after lumbar. And this was purely based on whichever symptoms were predominant. There was no study done to imply that any surgery had preceded over other, like cervical, where only cervical only had resolution of lumbar symptoms. So that was not studied in this study. Later on, there was this study, Korean study done by Miyamoto and Kikiuike, and just a minute. So it was a 17 patient study where clinical and all the patients which were included had proven clinical and radiological stenosis. The cervical patients underwent laminoplasty, of which one was posteriorly fused, which was a rheumatoid arthritis patient. Posterior decompression for lumbar decompression, and 3 were fused in them. So here all were done simultaneously. The mean surgical time and blood loss. So they argued on lesser surgical time, lesser blood loss, and these 17 patients, out of which 8 had undergone simultaneous with 2 teams running along, and 9 underwent sequential, one after the other by one team in a single sitting. So outcome-wise, based on JOA scoring, 10 patients showed good outcome. However, 7 out of 17 did not show any favorable outcome. These were the demographics. Later on, Dr. Robert Milonari had published this study where he had done a short literature review with the available literature then. This was in 2012, and here he had proposed that patient treated with simultaneous surgeries had a lesser postoperative stay time, had a faster recovery, and less perioperative complications, which we still follow with regards to a tandem spinal stenosis. However, he had proposed that again the surgical decision whether to do cervical or lumbar always preceded whichever surgery, whichever symptoms were more, like in cervical stenosis, patient with hyperreflexia and no lower motor neuron sign, like in concomitant lumbar stenosis, we see that lower limb reflexes aren't brisk as compared to upper limb when there is a mixed picture. However, in his study, irrespective of both, he had done simultaneous decompression and proposed to have a good outcome. So this study was done as a review article of many studies done in the past, and here he had given us like a guideline of as you can see, there are potential scenarios encountered clinically. So on history and examination, if history and examination findings point you towards CSM, but there are no presence of upper motor neuron signs in the lower limbs, like I said, hyperreflexia. So then we can suspect a concomitant lumbar canal stenosis vis-a-vis neurogenic claudication with presence of imbalance and bladder involvement. Then suspect concomitant proximal stenosis, whether cervical or thoracic. So presence of UMN signs with bladder dysfunction and compromise of fine motor skills. So the third part was history consistent with either cervical stenosis or lumbar canal stenosis, but symptoms were disproportionate. So here he said the suspicion of non-contiguous stenosis as a possible explanation. So here's a flow chart that helps us decide whether to address both or which comes first. So if the patient has CSM dominant presentation, of course we address the cervical first. If the myelopathy symptoms aren't so much, there are no myelopathy symptoms, but there is radiological stenosis, then we do a active range of if the CSM symptoms, the myelopathy symptoms are accelerated by active range of motion, then we address cervical disease first. If that's a no, then again we check for radiological instability in the form of flexion extension X-ray or a CT. And again, if it's a yes, we do the cervical first. If it's a no, then we are safe to consider lumbar surgery first. So in the table 4, we can see when to do staged or a simultaneous procedure. So here the author has mentioned if the patient is elderly or frail, fitness wise, age is more than 60 and has comorbidities, then it's better to stage it, whichever symptoms are predominant. So stage it accordingly, and simultaneously in case of younger patients who are younger patients with low comorbidities, and especially contiguous lesions means spanning two regions like cervicothoracic or thoracolumbar. And in such patients, even if we do a stage procedure, there's a potential delay in functional gains, as the second stenosis may not give you a better result if we do it at a later stage. So that's how he has divided the two groups as to where to do staged and when to do simultaneous. Next study again has described which one to do first. So this study tells that decompression of one stenosis alone is adequate to relieve overall symptoms in tandem spinal stenosis. So he wants to say whether either doing cervical or lumbar alone is the most logical option. So 47 patients with tandem stenosis were included in this study, and it was divided into two groups. Group A, where lumbar surgery was done first, and Group B, where cervical surgery was done first. Post-op outcomes were analyzed for a minimum of 2 years, and they were watched for deterioration of symptoms of the non-operative stenosis. So if the cervical was done, patient was followed up with respect to the increase in lumbar symptoms and vice versa. So Group A had the worst outcome. So in existing tandem stenosis, out of the 11, 10 needed cervical surgery at a later stage. Group B, where cervical was done first, had resolution of even lumbar functions and good functional recovery. And only 11 out of the 36 patients in the group B, which only had cervical surgery, needed a second surgery. So in conclusion, the author states that first stage surgery for cervical stenosis significantly lowers the lead of second stage lumbar surgery, which is 33%. And so hence, if at all decided to stage, do a cervical stenosis first. This is the demographic data, where he says that 67% of free of lumbar operations with 67% had no lumbar operation, no need for any lumbar surgeries, and need for second stage surgery for non-operative stenosis differs. As you can see, it has a significant p-value. This is one paper, but this paper has all these studies were retrospectively. There is no prospective study done yet. So even this paper proposes the effectiveness of cervical only decompression for patients with
the big factor here is that we don't know what they are calling lumbar stenosis. Because, in any given, it's like comparing apples to oranges, because in any given person, you will find some stenosis. Someone who has a tight cervical stenosis. So your interpretation, my interpretation, and this author's interpretation of lumbar stenosis could be different. Is it not?
In the inclusion criteria in all these studies had canal stenosis as graded by Kang et al., which was more than 1/3 of the
but
total
radiological or clinical? I mean, the thing is that most of these are radiological grades, and radiology often mismatches in lumbar stenosis with clinical settings.
Yes, sir. So all these studies, sir, they are not mentioned exactly how much was the clinical or radiological correlation.
Sir, in in our practice, typically when patient comes with predominantly claudication symptoms with fairly soft signs of cervical stenosis, to convince them to do both surgeries, what is your take on that, sir?
Personally, I may not even convince them. If there's just a radiological cervical stenosis with no signs, no symptoms, I just go ahead treating the lumbar stenosis. It's really the classic one that comes in, Jayesh, which I'd like you to answer from your study, from your research, that a classic guy who has a significant stenosis doesn't know about it because claudication is his main symptoms. But when you see him, he's clearly, walking a bit, incoordinated. And on checking, his upper limbs are brisk, his knees are brisk, but his ankle is lax because the lower motor of the ankle is compressed, but the lower motor of the knee is spared. So the knee is upper motor, the ankle is spared. He does give a history of slight hesitancy in urine. And, when you try to do his upper limb tests for early stenosis, you find all of them are positive. So what would be the, take on these guys?
Sir, if on radiologically, they do show a severe stenosis in the cervical spine, and clinically, if lower motor, upper motor symptoms are evident, then it is important to address both simultaneously.
Right, and that's what literature says also.
Sir, so the last study which I had shown, this study, they said that in spite of having lower motor involvement, the patients improved.
So no, many of your studies suggested that though you do this and you don't have to do that. You do the neck and you have to get away. So that's where I'm bringing in a contention that the lower is not so bad and it's not game for game. It's like this. It's overwhelmingly cervical and radiologically lumbar. It's sensible to do the cervical and keep the lumbar for later, or may not do also. But in a situation as game for game, both are significant, but there are no symptoms of cervical stenosis. The presenting symptoms are only lumbar stenosis, but there are overt signs of cervical stenosis.
So then we do both, sir.
Right. Anyone else? Priyank, Sameer?
Yeah.
Anyone else?
Sir, so if suppose if both are symptomatic, if both are
Not symptoms. Symptoms
I
of
got
the
it. If
lumbar
the lumbar
and signs are both.
if the lumbar is symptomatic, signs are both.
Yeah.
There are Indian studies. There are some old studies which say that tandem spinal stenosis give good result. It is safe. The Western studies say that if you have one out of the two, you do the cervical first and
Yes,
then you do the
correct.
lumbar.
Even though it is
Yeah, you do
asymptomatic.
the cervical. Even though if it is asymptomatic, if you have picked up the signs, if there is, if the reflexes, all of that point towards a significant significant radiological correlation with your signs, you do the cervical first, and the
Correct.
lumbar symptoms also improve. And then
Correct.
after that, if needed, you go and do the lumbar decompression.
Right.
Correct, sir. So, but then again, there was that review article from Australia. So that said that if the patient is young and robust and with very low comorbidities, then it's okay to doing both together. So this only comes into picture when there is a fitness issue, and then it needs to be staged.
Because doing both together is a simple option, right? Simple.
Correct.
If you do it, of course,
Correct,
you should
sir.
do it. And if the patient
Yes.
says yes, etc. The question is, you have to do one. It is a bit counterintuitive to imagine that you do the asymptomatic neck and leave the symptomatic lumbar. I don't know how your patient is going to tolerate that, because theoretically it's going to remain.
On that, it is argued that myelopathy is a clinical thing, and cervical stenosis is the radiological diagnosis. So if your patient has some stenosis on radiological but has a myelopathy symptoms, then it becomes imperative that if you have to do one surgery, then do the myelopathy.
Right.
And same thing is said in this study, which is done recently, published in 2021 in ESJ. So this study had 64 patients with tandem stenosis and who only underwent cervical decompression. So out of the 64 patients, 44 showed improved lower limb symptoms, and remaining 14% patient maintained those improved symptoms. And out of those 44, 30 showed relapse of symptoms at 2 years of follow-up. And then these 30 underwent lumbar decompression after 2 years. Out of those 30 also, again, only 28 underwent lumbar decompression and 2 were managed conservatively.
So I think in this case, there are a lot of individual. I really don't think so. I have been sort of looking at the papers, whatever have been put up, but you cannot possibly compare because each patient comes to you differently. So it is not right to say that if a patient has got both, you only do the cervical and you're going to get away. There are many large patients who come to you with classic neurogenic claudication, numbness, heaviness in the legs, pain, radiculopathy. And if they, on a screening MRI, or on examination, if they have exaggerated reflex, knee reflex, and on a screening MRI, if they have got some stenosis in the cervical spine, it doesn't make any sense to decompress that and hope that the lumbar symptoms will resolve. In fact, there are many, I would say, in my, so this is like at the top of my head, it's not that I have the data right now in front of me, but there are patients who I have listened to in detail, examined in the greatest of detail, and this is where your skills as a clinician and as a radiologist come to fore. See, you can either be mediocre and listen to the literature and say, "Nene, sab karne ka, sabko karne ka," or you use your brains and you see what the patient has. And there are quite a few patients who have decompressed the lumbar spine and told them that you have an issue in the cervical which may lead problems later on. And those patients improve in the lumbar spine and they may come up for cervical afterwards. Then there are those who come purely with, there are those who purely have cervical symptoms, means they have altered gait, myelopathic gait, they don't have claudication. Those are the patients where you can only do a cervical and get away. But you cannot club together 60 patients and then try to draw a conclusion out of that, because that cannot make sense. Each patient has an individual,
I agree, sir.
And each patient has got different varying degrees of degeneration in the lumbar and cervical, and each one has a different set of symptoms. So I don't think you can really do that. And very often our patients come with lumbar canal stenosis and not with cervical. See, the other question which you would ask yourself is that sometimes when you look at the radiology, is that would you have operated this patient's cervical spine if he hadn't had any lumbar problem? Or are you operating him only because he's on the table and you're going to do a tandem? So if by itself the cervical stenosis did not merit surgery, it doesn't make any sense in combining it with the lumbar.
Absolutely,
right. So that's
sir.
pretty much what we were, Samir. Thanks for those inputs.
Yeah.
Jayesh?
Sorry, beach mein I had switched off. I had gone to get my dinner, so I had switched off the sound.
Yeah, we were spying on that, but that's why once you came back, we wanted your opinion on this. Jayesh, anything else from your studies? Any other?
No, sir. This is the latest study. This is a 2021 study which had said that they even after those cases improved, out of those 14 which kept improving, they had to reoperate. Stage the lumbar in 30 of those cases. So it's safe to say that doing simultaneous does make sense, at least in our with respect to our clinical judgment and our ongoing protocols.
Fantastic. So,
sir, I've got 2 points to add. When I presented my paper on tandem spinal stenosis, there was a simultaneous paper by Michael Fellings on cervical decompressions, where they had they had studied the track changes pre and post decompression. And at that time, we had come to a debate as to why, where he had clearly mentioned that even what we discussed, that if there is a cervical and a lumbar problem, you do the cervical first and the lumbar symptoms start getting better. But an unofficial discussion roundtable with his team, we realized one thing, that their lumbar stenosis is nowhere close to the type of stenosis that we see. That is one thing. So that's where the study might be a little flawed. The other thing is that in an Indian scenario, our Indian patients are still not accustomed to the fact that you do 2 small safe surgeries, whereas you do 1 big surgery. Here the people are like, whatever you want to do, you do it one time and get rid of it. Like if you try to tell them also that you're going to go and do 1 surgery now and 1 surgery later on, you lose 50% of the patients. So in a practical perspective with our Indian scenario, I think do it one time will of course give a better outcome, in that manner.
So quite true. But I will still tell you a counter to this from my experience, that I've had a bunch of people, Indian patients, who have had, like I said, an asymptomatic severe stenosis, which has got a lot of signs but no symptoms, who have come for claudication, and they were all set to do the lumbar decompression. The minute I said, I need to do this also, because I was really not happy to leave it alone. It was so tight. I thought on anesthesia also they'll get a quadri. And they actually went off. They ran away. They didn't come, because then they thought, this guy's fiddling around with something. It doesn't hurt me. My hands are working well. I can sign. Why does he want to do my neck? So I think swings both ways, the level of literacy and level of understanding. So it's not always.
But, sir, what Priyank said is also right. Our Indian population is less receptive when it comes to the surgical point of view or surgical intervention.
Correct. So I think a good way to do it,
one thing which Priyank mentioned, and it was going to be my next statement, but I just want to emphasize it again, because I think some of you may have missed it, because he said it very subtly. Honestly speaking, in the West, what they call lumbar stenosis and symptoms and what they operate, I would not even look at in the OPD for 1 minute. Means they are very hardly anything, and they say, oh, he has a tight, he has a stenosis and he has symptoms and he's disabled. And that is nothing. Our patients are nothing like that. Our guys really come with stenosis, tight, very roots are compressed. Like you saw this last MRI, which these guys, Harshal and all showed. That sort of stenosis. Yes, so now when somebody has that sort of a stenosis, the one before this, like the one with that sort of a stenosis, even if they've got something in the cervical spine, you can't say I'm going to operate only the cervical spine and leave. See, this stenosis you can't leave. You can't say I'm going to operate the cervical spine and it's going to get better. Out of the question.
Correct, sir.
Totally agree.
Yes,
whereas I'll tell you one thing.
So
go back one slide. Go back one slide.
This one,
yeah,
sir?
Here everyone said we are going to operate on L4-5 and we are not going to operate on L3-4, right? The L3-4 is what they would call as a severe stenosis.
Correct.
In UK. Sir. But we are not even looking at it. We are not even planning to operate that. So that is the difference.
Pretty much.
So I think what is your...
Munjal.
Sir, have you burnt your fingers in which there is asymptomatic cervical spine, no signs, no symptoms, only doing lumbar and your lumbar has not improved?
Yeah, I have actually. Lumbar has not improved. The gait actually worsened. I've had a situation where I didn't address the one situation, but it was bad enough, which is why right now I don't get into that. So I
So
did
there
the
is
cervical.
So I heard lectures from BRD sir, and he used to say that when you do lumbar stenosis and your crouch improves, that's how your cervical may survive how it is. But sometimes it backlashes where your lumbar does not improve. So all the papers are saying that lumbar will improve by doing only cervical.
So there
But
is one study which says that if your
Yes, it does.
lumbar canal stenosis is treated, the posture improves, the balance
yes, that's
improves,
what.
and the forward
And your
imbalance
neck,
of leg improves.
That's
But
why.
yes.
it is too tacky to imagine because it's a bony compression.
Yeah,
And
once again, we are talking of severe stenosis. I don't
yes,
think
sir.
position will make a difference.
True,
And,
sir.
claudication comes from lumbar spine, but incoordination comes only from upper motor. And
Correct.
so even if the claudication goes, their gait worsens and then you're stuck because then you're, they don't even experience the relief of claudication because they're barely walking.
So with
So
this,
there are many surgeons who believe in staging only. So in that, if patient comes with say cauda equina, then we always do lumbar, and which we see cervical is always involved. Then how much we should differentiate between the two surgeries, because we always do is tandem only in our unit. But if you have been there are surgeons, so how much we should, at least if they are unfit, it should be how much difference should be there in terms of weeks
How
and
much
days.
time, duration?
Yes, sir.
I think it totally depends on the pathology, but like a ballpark figure, like in orthopedics, you say 6 weeks or 12 weeks. So I'll say 12 weeks here. But
Yeah.
I'm going to give a strong message out here that you create a team and do a tandem at the same time.
Yes,
Like,
means if
don't
you
be-
don't have a team, then
create a team. Like, don't,
Yeah.
if a patient is willing, just do tandem. If a patient is unwilling, there's zero disadvantage of doing tandem, barring the socio-economic aspect. Economic because you have to charge for 2 surgeries,
Yeah.
1 surgery, whatever, and then you have to involve another surgeon. So I think you should get over that and just do. If they're
So-
two significant tight stenosis, just do both of them.
Abhay, since no, right now all are almost your guys and none are, like, they're all your guys. But I just want to say one thing, and when it comes to this, and this is a medical point, is that when I do tandem stenosis, if I do both, I do not take the incision in the lumbar spine until my lamina is out. This is because, according to me, I am very terrified of a cervical laminectomy for only one thing. That is, when you take that last lamina out at C3-4,
Bleeding.
sometimes there is this epidural bleeding, and I have had 2 or 3 cases where I've had to abandon the rest of the surgery and come out. I don't want to be in a situation where I am in a big soup in the cervical spine and the lumbar spine is exposed and I have to suture it and take the patient out.
There's
So
another-
my planning is this way. We have 2 teams as such, but the exposure down starts when the lamina is out. So one exposure and one closure can be simultaneous, but it is not that both will be attacked simultaneously. So that is my thing. And that's it. So therefore,
Great
I am
point.
not.
There's another point, Samir, on the same lines, that if the lumbar guy busts the dura and you have a CSF leak, the cervical guy is in trouble because it decompresses the
Yeah, it will
muscle
flatten
slightly,
down. Yeah, it will
and
flatten.
you are lost, and of course you start bleeding. So I think
Yeah.
you have to keep that in mind. Fortunately, we have not suffered that neither bleeding nor the CSF issue.
So, but this is my strict protocol that exposure starts when the lamina is out. So you can there is still an overlap. It is still quicker than doing them separately.
Yeah.
But I don't do both together.
Right. Great.
And
That's
I
why
totally agree
my
with.
unit is called I am spine, not we are spine.
No, I agree. I agree with Dalvi sir here because I experienced a similar thing where I had to close the lumbar spine because the anesthetist just wouldn't allow me to go ahead with the
I was
surgery.
washed up with you,
I
sir.
think
I was.
Jayesh was washed up with me. So especially for our guys who are practicing not in Bombay, outside, where they don't have a lot of expert hands, maybe taking up a tandem spine surgery should be thought about before, because it happens like
get a second competent
like a
surgeon,
proper
right?
consultant on the other hand, not someone who can handle the surgery independently. Like just for the boys out of Bombay, they should just be aware about this thing.
I have a
Like,
question
we were
regarding
about to lose the
decision
patient
making.
that time.
Yeah, Jayesh.
Yeah.
How often does a SSCP help in these complicated, whether to do tandem or not, in making the decision to go for a tandem?
According to me, the decision is grossly clinical. I use SSCP to sell this surgery to the patient, because the minute I say you need to do this, they start because they've come for something else. I say, you want to prove it, you do the computer testing and the computer is showing that your nerve is not functioning well. And then they do it. Prospectively, I tell them, कि उसमें आएगा तो करना पड़ेगा. Then it comes and then they are convinced. So it's a good practice trick, but I don't think I don't think it's going to matter.
Samir sir, do you do SCCPs for patients?
Very rarely, because I think electrophysiology is a very inexact science. It's a very inexact science. So I would very rarely do it or depend on it. Sometimes patients come with it, but I would very rarely do it. I would very rarely ask for it. Not that I never would, but I would rarely ask for it.
Okay.
For a wonderful discussion on tandem stenosis. Basically, as we learned from this discussion, that always examine the patient thoroughly. Always have, whenever possible, always have a long whole spine sequence ready with us. And decision making typically depends on the symptoms, signs, and then availability of the resources which you have with regards to a co-surgeon also. Coming to the next case.
One more point I want to add, Harshal.
Please, Punjal.
Yeah. So the thing is, tandem, we are always focusing on cervical and lumbar. There can be thoracic and lumbar also. So what I heard and read in literature, means I was looking for AO spine and all. They say that for thoracic, whether it is seen in MRI, you should always decompress. That's what the thought process is, because the cord never fall back. So that's what I want to add. What do you want to say, sir?
What was the exact thing?
Means there is
triple tandem or thoracic plus
thoracic and lumbar is there. So we always say tandem is cervical and lumbar, but it can be thoracic and lumbar also. And there are hyperreflexic signs are there. And even if they are not there, they are saying that thoracic you should always decompress because there is no more movement for the cord is there. So that's what they say.
Yeah. So triple tandem is a very all the OLFs are typically triple or quadruple tandem. But I think the rules for me would remain the same. So I've had situations where I've not done the thoracic and done the lumbar and just warned the patient about a thoracic. And there are patients who have done 3 times over. I remember doing Dr. Agarwala's relative, apparently. First, lower thoracic, thoracolumbar. Then after 2 years, the next OLF became surgical. Then after a few years, the next one became surgical. So I am not sure on a plan, but I would go by the same system. That if both are very severe, just go for them. If one is less severe, leave it alone.
Sir,
is it true that
specifically regarding dorsal stenosis, both Samir sir and Abhay sir, have you ever noticed a patient with a symptomatic dorsal stenosis, a symptomatic lumbar stenosis, where you have done the lumbar spine and then it's decompensated and the patient has come up with spasticity?
Yeah, pretty much. So just like I said,
after,
cervical, no, same way.
Or after some time.
Yeah.
No, like immediately after or after
almost
some time?
Immediately. Yeah. Almost immediately.
Okay. What about the other way around?
So I'll just tell you one thing, that for the I am less forgiving for the dorsal stenosis than for cervical. Means if an MRI shows a dorsal OLF, especially with a signal change, and the patient comes with symptoms of lumbar canal stenosis and has a tight lumbar stenosis, I would invariably do both together.
That's what Munjal
I may not.
Yes, sir, that's what I have read. That's what I have read, Samir sir.
But dorsal I would. Because dorsal, I think the problem with dorsal is that the area for the cord is much less. And the amount of cord dysfunction over there, like the amount, how can I put it? The number of fibers for the volume of the cord is much less. So if you have and usually these are D10, 11, D9, 10. So if you have a D9, 10, D10, 11 OLF, those facets are crowded and you see a spot over there, the signal change. That guy is definitely a villain and it has to be decompressed.
And that's what, sir, literature also says. That's what I was reading, sir. That you can't leave thoracic, sir.
And thoracic, you like cervical, there are 2 distinct symptomatologies. This thoracolumbar, OLF comes like hidden behind the LCS. So, it just turns up after you've done the LCS decompression. The cervical, there is an obvious problem you can identify as a separate problem. Here it gets camouflaged. That upper lower motor does not happen. Harshal, we are 10:30. Do you want to just do a couple of more cases and leave Subhanshu's? Because Subhanshu's discussion is a big one again.
Yes, sir.
Dynamic compressed dynamic stabilization.
Yeah, because there's again reinvigorated interest in dynamic stabilization now.
Yeah, I went
with
through
adult spinal deformity.
a whole new thing. We can keep that as a separate discussion. Dynamic.
Yes, sir.
So if you have some other cases,
I'll just skip through this case because this was one for the Subhanshu only.
Yeah.
This again is a 66-year-old female on chronic than right lower limb pain of duration. Neuro was grossly intact around 4/5. There was a pain inhibition for her, and she came with these X-rays and MRIs with us. Aditya sir is there. Aditya sir, you want to take this up? Munjal?
Gajendra, maybe, or
Gajendra is there. Yeah.
Tejasvi, whoever is awake.
So she's having some degen scoliosis here, and there's a significant moderate to severe lumbar canal stenosis. She's symptomatic also, and any takers for plain only decompression here, or you want to do some more investigations?
I usually, I mean, since you asked any takers, so I hate these patients completely, and I try my best to get rid of them in various conservative ways: physio, exercise, pregabalin, blocks, blah blah blah. But if this patient does come to me with a lot of leg pain and moderate back pain, what I usually do is that tell them is I look after your leg pain and I don't know anything about your back pain. Like I can't promise to treat your back pain, and I will just do interlaminar decompressions for these. So I will do, I will see which are the stenotic levels, which here seem to be, because whatever I can see is 3, 4, 4, 5, and 5 on that left side. No,
yes.
Right side pain she has. Left side pain she has, sorry. So
Left side, yeah.
5, 1 looks okay. Usually 3, 4, and 4, 5 are there. So I would do interlaminar decompressions without destabilizing too much. Because see, if you don't do that, then for this patient, then as I'm saying, I'm seeing only failures. You know,
yeah,
I'm seeing only failure. I'm saying that whatever you do, that's going to be worse. Like no matter what you do, you'll get an adjacent level, or you'll get a PJK, or you'll have to go to sacrum. We had this discussion, I think, just maybe 3-4 days
last week only.
Yeah. So I'm just worried about even starting to operate on these patients, because that is the beginning of the next procedure and the next procedure and the next procedure.
Very
so if I can get away with only that, then maybe.
Harshal, even I would hard counsel her for a second surgery and still would do only decompression.
Okay, sir.
So I want to throw in a slightly different angle just because there is time for discussion. That I'm not impressed with the stenosis. The stenosis is moderate at best. And if she's got such disabling symptoms, I feel a decompression alone may not work for her. Also, she's young for my money. So I may think of doing a short segment fusion for her along with decompression.
Sir, and again, short fusion versus long fusion. Why short fusion, sir?
So, I mean, just cursorily, I'm thinking this is a balanced pelvis, balanced spine, and the curve is, I can see the bottom and the top of the curve. That I can't see the sacrum in the standing X-ray, but in the last one, the sacrum was nice and flat.
Yeah.
So, assuming it's that, I'm still thinking this is a balanced spine. So, I would still think of a short. When I mean short, I mean like in the lumbar spine, not going into thoracic spine.
Yeah.
Can I add something here, sir?
Yeah, Akshay.
I will go with your point. So the amount of stenosis is again not very much impressive here. And of course, we see a lot of osteophytes there, those anterior osteophytes. But still, in most cases of the degenerative scoliosis, claudication and root pain or radicular pain, it comes from the fact that the vertebrae, they might translate over each other. And traction radiculopathy is what they call it, is more often the cause of the pain, especially in the cases where we don't appreciate a lot of stenosis. 1 point. Second point, sir, the other day when I was texting you about the coronal imbalance in the degenerative scoliosis, in this patient, I would definitely want to have a look at the whole spine X-ray before planning any fusion for this patient. The reason being now, a lot of things is being talked about the 3 types of coronal imbalance. The patients who are decompensated towards the convexity of the curve, they tend to worsen in terms of their coronal balance after surgery. And partially, again, it's related because of the fractional curve at lumbosacral spine. Now here, I think she is grossly balanced. Again, if we see at C7 plumb, it's more or less passing through the midline of the sacrum.
Between the femoral heads and the...
yeah. So I think if C7 plumb line is passing through the sacrum, it's passing through the sacrum in the AP X-ray, then this patient, of course, we can label that she is globally balanced. And there, we can plan not a lot of correction, but an in situ fusion for sure. Also, one question, sir. In case if you choose to, and again this question goes for both, sir, Samir sir as well as Abhay sir. If we choose to fuse this patient, where will you choose to stop proximally, T10 or T2?
No. I would stop at L1 maybe.
L1 only.
L2 or L1. L1 maybe.
So I talked about lumbar only.
Okay. But then again, sir, another thought transpires that stopping at the thoracolumbar junction into the kyphosis again can be a recipe for the.
So I am not a believer of that. I look at the kyphosis, and if I'm stopping on the top of a kyphosis, whether it's T10 or whether it's L1, I'm worried because it's going to fall off. Here, if you see, it's a fairly flat thoracolumbar junction. So I won't, just because it's called L1, I won't worry about it being a junctional bone. So personally, I don't worry about stopping at junction, but I'd like counter views from others.
Go back, Harshal. One other thing why I would probably jump on doing a decompression alone is the sitting and supine. If you see, there's not a lot of translation and collapse between the sitting and supine AP X-rays. And like I've just seen a lot of my seniors follow-ups and everything. And the patients who have not really done, one thing I've noticed in all of them is when we do a sitting and supine X-ray, there's a clear collapse that happens. So that's the reason why I would still think in terms of a nice wide decompression, counseling for a big surgery in the future.
Yeah, fair enough. I mean, it works both ways. Yeah. So both points.
Sir, any thoughts on gap scores recently? Because a lot of people, they're talking about gap score and especially maintaining that differential lordosis between L4 to S1 as compared to L1 to S1. So one of the theory is 66% of lordosis in lumbar spine, it comes from L4 to S1 segment as compared to the entire lumbar lordosis.
So I mean, I'm actually getting tempted to read because I think the lower main lordosis is looking quite good. If at all, I'm getting tempted to do interbody at the upper and get her back, and rather than worrying about the lower one. But I agree. I mean, we discussed about the gap score in the last session. And I think we should pay more attention to it because it's slightly not an intuitive scoring system. So here forwards, we should be thinking about it. Maybe we can do a session on that also.
Sir, what's your take on OLIFs in these cases? Doing OLIF and...
Yeah, so I think anywhere, wherever you need more than a 2-level T-lift, I think an OLIF comes into play. Most of us are very comfortable doing 2-level T-lifts. When I mean comfortable from the point of view of surgical time and blood loss. But the minute the T-lift goes into 3 levels, so more than 2, I think there's a option of staging it versus doing OLIF first and then like a front and back, whether you do an OLIF or whichever way you do. So in this particular one, I don't see a good. I mean, the only reason to do OLIF is that the interbody is going to happen at a place where OLIF can be done. 80% of the time, the interbody is needed at 5-1 or 4-5 where OLIF can't be done. So here, OLIF is possible. So I think if you're an OLIF surgeon, you may look at this like an OLIF candidate. My issue about OLIF is it's 2 surgeries, while 2-level T-lift is a single surgery. So I'm just giving you my point of view.
Sir, how your experience has been with OLIFs? You done OLIFs?
I have done one OLIF for one case because it was an adjacent segment degeneration. So, but I can do anterior surgery. So I've done anterior fusions many times. So I'm not saying no to OLIF here because I don't have the capability of doing OLIF. No, I can even call someone and get an OLIF. My worry about OLIF is that it's 2 surgeries. So you have to do an OLIF, then you have to do a posterior surgery. So it's worthwhile if it's giving an advantage over a posterior surgery. In my opinion, if the posterior surgery is going to go to more than 3 level, like 3 or more level T-lift, the blood loss and time taken is disproportionate. And that's where I would do a 2-level or a stage surgery, either an OLIF followed by a posterior or a posterior release screws, go back and come back and do a T-lift and fixation. Right. Is that clear, Kushal?
Sir,
is that
and sir, can I ask Samir sir how his experience has been with OLIFs? If sir is around.
I am around and I have no experience with OLIF. It sounds like a very attractive concept when other people are presenting it, but as he rightly pointed out, I think it's a bit too much. Like I can't understand. I cannot envisage counseling our Indian patients who come to us that we are going to go from the front and it's got its own set of complications and then go from the back. They'll say कि हमारा back में दर्द है तो पेट का क्यों operation करते हैं? So
plus
the one who's been doing OLIFs a lot is Ayush, and his patients are the railway patients who really have they have nothing to say. They have to listen to what he says. They can't dictate.
If you have a hammer in your hand, everything around you looks like a nail.
It looks nice, and very often when I've done a surgery, I say this would have been a good case for OLIF if I knew how to do it. And Abhay keeps telling me I'll know how to do it because I have great experience in anterior surgery of all types. But some of the other, I don't know, it doesn't appeal to me. That's what I feel. I just feel they're going round and round in circles to make it look. They'll do OLIF, then they'll do minimal invasive, then they'll do transfacetal screws, then they'll do little decompressions. So they're just doing too much what can be done with a simple one incision and just finish it off. I just feel they're just going round and round in circles. And the OLIF also, what you're seeing now is after many other failed things have been given up along the way. When they were doing the X-lifts and all, those patients used to have 40% patients with femoral nerve palsy. How can you operate on a patient with back pain and give that patient a femoral nerve palsy? I mean, it's like unthinkable, and vascular injury as well. So that's why I've sort of kept away from OLIF.
Kushal, this is a slightly prejudiced group, but if you ask the same question to a different set of surgeons, you may have a different set of answers. But what we said is also quite relevant, and we don't definitely lack the skill set to do an OLIF because it's a much easier, it's like an anterior surgery given on a platter. It's a much easier way to do an anterior surgery because the instruments, etc., are so much easier. So it's like a guy who is used to driving a Maruti is now given a Ferrari to drive or a Mercedes to drive. But it's just that I don't, or even Savi does not see the utility of that surgery in the bulk of the patients. There are one-off people where it may be handy. Going forward, Harshal?
Yes, sir.
Okay.
Yeah.
No, fine, sir. That's okay.
Please, sir. Ask Akshay, sir.
In fact, rather two questions. So there is very serious lack of consensus between when to do interbody fusions and when to do posterior column or 3-column osteotomies. And also, that was the first question. And the second question was when to basically opt for correction at the apex of the curve and when to opt for the correction of the curve at the base, as in between L4 to S1. Again, literature, there's not a lot of thing mentioned on it. And again, the meetings, like last time as they had a huge discussion on this, but then again, outcome was nothing. So again, the entire audience was left to, in confusion. So I just wanted to have your
Personally, I would not do a 3-column osteotomy for these old people with a degen scoli. And posterior osteotomies, I would do for almost all of them. Like doing facetectomies nowadays, especially with the ultrasonic cutter, it's a bloodless, quick procedure. You should not miss out on that. And that gives you a great chance to create lordosis. So if I want to do one step ahead, I would do an interbody, not a 3-column osteotomy. Very rarely, I've had 1 or 2 occasions where I've had to do a PSO, like a PSO, which is a much less damning surgery than a 3-column osteotomy to get better lordosis after doing a TLIF. Samir, if you have to say something, or anyone else also in the group.
Yeah, so this osteotomy for degenerative spine, I think the cases, because it is because in the West, they operate a lot of these patients that they land up having to do them. If we are only going to decompress or we are going to do these small fixations, we're not going to land up with them. What happens is if you have a patient who's been fused very badly in a flat back and you have to revise that and you believe that a revision is going to help that patient, that is when you would have to do like a 3-column osteotomy, or basically a PSO,
Yes.
Like I said, I've never had occasion to do it, and I would think 100 times before I really plan one.
Sure. Thank you, sir.
Moving ahead, sir.
No, so what happened to this patient? This is very interesting because this patient is going to not do well.
We have a short, it's our patient or whose patient?
Our patient, sir. We are 1 year follow-up. Though X-ray looks little, there are a lot of critical points on X-ray, but patient is symptomatically much better.
I'm worried about the top end.
Yeah.
If you see, it's looking very dangerous.
The top is the big worry.
She is the COVID wala, I think. Immediate surgery.
Also, sir, can I highlight one more point, sir?
Just last March only.
If we have a look here, the same thing which I was talking about coronal decompensation post-op. Now, if we look on a pre-op X-ray, she seemed to be slightly falling towards convexity. And on post-op X-ray, we see she's falling more on the convex side. So these are the curves.
Coronal decompensation.
Yeah, these are the patients, with the coronal decompensation towards convexity. they have more propensity to land with the coronal decompensation post-op or adding on post-op, sir.
Abhay sir, in the retrospect, looking at the X-ray now, if you would have still taken the decision of fusion, would you have gone in the thoracic spine or would you have just selected the same level?
No, even like this lady, no, I will not. I know it's concerning, but I will put her on. She's 66, photio and extension exercises. That'll be my formula to bail her out of where she's headed.
So one more point which you just said about extension exercises.
No, sir, I get that. No, in general, if we have to start redoing this, will you still do a L1 to L5 or would you now, like, you know,
think about it.
the entire
you
thing?
guys think about if we had gone to T10 also, no? Just in your head, just extend this 2 levels higher.
Yes.
And you're going to still see her falling off on the top. So just think about it. You look at the post-op X-ray and in your head, just put 2 more or 3 more screws on top. I don't think you're getting it right by doing that. I mean, if you desperately want to get it right, you do much more at the bottom. Like I said, interbody fusion to enhance the lordosis and pull her back. Then
getting
you
the mental balance corrected.
Yeah, then you may win it. Otherwise, you'll have to go to T2 for all of them.
Correct.
So this is like radiological adding on proximal. So we don't have to treat that.
Radiological.
So one more thing.
Like AS, we see only distal add-on. Radiological is different than clinical. So this is the same thing which I feel. So.
Yeah, but it's only 1 year. So the verdict is still out.
So one more thing which I would like to add here, which I saw Nash Qureshi, he used to use this criteria. Now that's completely anecdotal and there's no literature background to it. But, you know, choosing between T10 and T2, he used to assess the extensors of the patients. And patients with weak extensors, he used to go in them invariably till T2. And patients with good extensor strength. Now again, the only way to test was subjective assessment. There was no objectivity to it. And if patients had a good extensors, he used to stop at T10 rather than avoid going higher in those patients. The only reason that he used to say is with good extensors, these patients don't tend to fall forwards. That's it, again, just anecdotal opinion about that.
Whose opinion was this?
This was Nash Qureshi, sir. Nasir Qureshi. Again, this guy, he do a lot of adult scoliosis at Queen's. And he's looking into his subjects about that.
So this was a case you're talking about sometime back. A 62-year-old female, 9-year-old posterolateral fusion was done at L5S1, and for first 3 to 4 years she was much better. Following that, she started having bilateral claudication, which is now chronic, and she has taken more than 8 SNRBs, and every time she takes SNRB, the effect lasts little less. And she's come with this X-rays and MRIs, which we have in front of us. Priyank, sir, you want to take this up?
Priyank knows not this case.
Yeah.
Yeah, sorry. The question for you is how to go about with this?
So basically, patient is having chronic bilateral claudication. Patient is now taken 8 blocks, and she's every time she takes block, she improves, but the duration is reduced, and last block lasted only for 1 week. And she's high demand lady. So she stays at, she has her own resort and everything, and she wants a lot of activity. And this is her current images.
Basically, it's a mobile adjacent segment degeneration.
Correct. So it requires surgery, extension of fusion proximally. Harshal, can you hear?
Yeah. Just lost my connection. Yeah. So extension of fusion proximally, posterior, anterior, OLIF. What will be your choice?
Oh, for this with experience, posteriorly extension of fusion.
Okay. Anyone wants to OLIF here?
Yeah. So this, in fact, this is an ideal case for OLIF because the level is 4-5. The access is easy. You've got a tall disc, and you basically
there's no stenosis.
Yeah, exactly. So it is a dynamic stenosis. There is no posterior central stenosis. So this is kind of an ideal case for OLIF, where you just have to stabilize the segment, and you will get the necessary result that you need.
So that
sorry, I completely disagree with that. if you do a OLIF, you're not going to fix it posteriorly?
Yeah.
So that means you're going to open posteriorly and you have to remove that rod and put screws and put a longer rod, right?
So Harshal, because we're running out of time, just show what we did, na?
Yeah.
Because I mean, I thought like that you know, you don't need to do anything from the back, and there was an option of OLIF with screws and plate from the front. So that's what we did here, but at least temporarily it failed. You have the X-rays, Harshal?
Just a minute, sir.
He did well for 6 months, then it started to fail because the anterior fixation was nowhere good enough. It was like a Mickey Mouse fixation. And later, and now she's held on. I've not needed to revise her, but it was like a flop show. Like then you started thinking, what the hell? Why is this OLIF even there? I would have done a good job from the back, you know. So the well done OLIF, mind you. We did a good OLIF. Yeah.
But OLIF you have to fix on the back also, no? There
was an option of OLIF with plate screw in the front. That's the post.
Come on, Abhay, for a lumbar spine L45, this which is now in a L5S1 fused, where this is L45, how can this have any hold?
Agreed. So it didn't. But on the bad side, she started to collapse. On the good side, now it's 3 years, I think, post-op, and we've not had to revise her. We held her down with this Forteo and all that. That's a separate discussion. But she's fairly mobile, and she's pretty much on message with me and all that, but she's not asked for a redo. We had her done by Taylor from Australia, who's a OLIF king. And, you know, we did all the right things for her, but we've not had to redo her. We have a flop X-ray, Harshal, aage ka?
Flop X-ray, I'll have to just check. So I'll get it.
Doesn't matter.
So we are not done pre-op CT in her, and the criticism was there might be lysis at L4. That's why this fails.
And
not lysis, the other
pseudoarthrosis basically.
Yeah. So L4 we are not done CT pre-op in this case, sir.
But I think
one other criticism was if you go back to your. Sorry, sir, I broke you.
I think what Samir is saying is far more relevant. It's a Mickey Mouse fixation for an L4 level, L4-5 level, and we should have not even dreamt that, you know, it's going to do something good for her.
Yeah. One other thing was that it was already fixed. Like if you there was already a screw in L5, and whenever you put screws, there's a little bit of osteolysis around it, and there's weak bone. And when you again try to put screw in that same area, then it's not going to hold back. So sir, just going back, if you would have done the same thing with a OLIF cage, and instead of you know, using that screws which are not really that good, if you see the size of screws and everything, and done a standard regular anterior fixation with your staples and all, maybe this would have just held on.
No.
It wouldn't have.
Abhay, this has backed out laterally to one side.
Yeah.
Wow.
But she's fine. I'm just going through her messages. So it failed, na, basically. The cage started spitting out the implant. But after this, it's not failed. And this must be 1.5 years or 2 years old, this X-ray.
Yes.
But where the hell is that lying, man? I mean, on what?
I did a CT also. It was away from any major vessels. She's an intelligent person. So she knows. And like I told you, the Australian guy also saw her. And all these things were discussed. And should we do a revision, etc. But anyway, it's lying. She's safe. Interesting.
But Harshal, if you see the last X-ray, I can still see the lysis. Can you just show that?
Last X-ray, on see, just a minute.
Yeah.
Guys, we should call it a day. It's 11.
Yeah.
Yes.
11.
Yeah.
If you see, sir.
I know.
Yeah.
That's why I think only that time the concept was maybe we were wrong, that only plate. But if there was no lysis, it could have still hold. It is still holding, but the implant is back out.
But I'll never do this surgery again, for sure.
Yes, sir. It's
Never again.
Yeah.
Your S1 screws are also not very happy here, by the way.
No, but they are old. They are 10 years old.
That was elsewhere operated, I guess.
Yeah, elsewhere operated.
This was an open OLIF.
No, it's a proper close. If you see the photos, no?
Yeah.
I have interop photos. It's proper, like a proper OLIF. You want to just allow me to share?
So I was there for the case. That's why I told, after experience, I know that I'll do a posterior for this.
Yeah.
when Harshal asked me the question.
So basically, I wanted to take this to dynamic compression, and secondly, a role of indirect decompression, because there's a lot of talk about indirect decompression. So which are the cases where we should,
So if you just before finishing, since you spoke about indirect decompression, Ayush, who does OLIF a lot, he's set a protocol and he's happy with it, where he puts an anterior, he does an anterior in OLIF cage. He does not do posterior fixation. He gets the patient walking for 2-3 days, assesses the claudication. If the patient is claudication, he does a posterior decompression. If there's no claudication, he just puts posterior MIS screws, and that's the end of the procedure. So regarding indirect decompression, that's how he's using clinical criteria to see if just by doing an anterior interbody cage, does the patient get relieved of the claudication.
What he does when he leaves,
just,
leaves the railway.
See, this is a closed group, and anyway, even in open groups, I'm brutal. The question is this: that this is such a childish thing and such a theoretical thing. We have done proper super decompressions. Which patient is okay on the day of surgery? They scream and shout, and after 6 months, they may come and tell you, "Aata nahi sudhar le." So what does he mean by saying that he's put in a cage anteriorly and the patient make a walk the next day? This is something, the fantasy land. It's like from Avengers or something. That you put a cage anterior and now the patient make the patient walk and his claudication gets better the next day.
That too, and it's an impractical approach. You can't be doing so many things for one person when you can do one thing.
No, I totally don't agree with that, especially because post-op day 1 to you're on IV pain medicines and all, and you cannot really judge, but that's something that he does, so I thought I'll just share with you.
I mean, he won't do it once he's in private practice. In the railways or in municipal, you can do what you want.
I'm 100% sure.
Yeah. You can't, your patients won't accept this kind of a surgery that ek karega.
And sir, most of our Indian patients, sir, and also it's a very practical thing. If you are trying to do a 2-level OLIF with a MIS fixation, which means your implant costs are going to somewhere around 5 lakhs. Indian patients can't afford this expensive implants.
So I think now it has a role, but it's a very, very limited role. I think in the big major adult scoli, you have to do it. You have to do 3-level anterior or 4-level anterior. I think you can do OLIF and, take the patient back and then do a separate procedure. But I think that's a limited rule. I don't think it's as
now, sir. Now they are doing is one stage also, but the thing is that you have to decide pre-op only whether you want to do MIS or you want to decompress even after you put OLIF cage. To do after this putting cage and after 4 days, I think is practically impossible in private practice for sure. Even in railways, they are doing is a different thing. But to decide pre-op is better, that we want to fix it posteriorly by doing MIS or you want to do decompress. That's what I feel, sir.
Chalo, it's been a lovely session.
Yeah.
Thanks for hanging on, all of you. Especially
just one last thing I wanted to share. When you said that anterior 5-level and 4-level anterior, this is just a unpublished audit of the Queen's itself. 5-level anterior, very high rate of complications, sir. Especially, IVC, all those patients, almost 12 patients were there in that series. And of the 12, 8 required IVC filters post-op. So, I mean... It's like not to say much about it, but again, the figures they say really bad about those surgeries. So things are not really good.
Right. Thank you. Hriday or Harshal, you want to wind up?
Yes, sir. Thank you, Samir sir. Thank you, Abhay sir, and thank you for a wonderful lecture on ERAS by Akshay. It was a wonderful paper, and.
No, I mean, definitely, there's a lot to learn. But again, I would really appreciate, and I'm really working hard on it to find the Indian version of ERAS. As Samir said, gave a very good criticisms, in fact, and also ideas to work on. But I think hopefully we'll come up with an Indian version of it soon.
Yeah. So complex lumbar canal stenosis is still a thing which we have to. Basically, there are a lot of associated pathologies which we have to understand and apply, because each patient is individual. We have to make sure that his clinical scenario is quite understood and then plan the surgery, because fixation, fusion, Indian population, there are a lot of criteria we should look for.
All right. Thank you so much. We'll be back soon. Thank you everybody. Thank you.
Thank you. Good night.